Up next, we have Dr. Ben Wildman Tobriner. And a little bit about Dr. Ben. It's easier to say that. He's an assistant professor of radiology at Duke University Hospital. He has subspecialty training in abdominal imaging and director of the Abdominal Imaging Fellowship Program. And a lot of details here that I'm sure he'll dive into as well during the discussion. But we appreciate him coming up on board. He's going to be doing some interactive stuff as well, too, so it'll be fun to see this as well. So if you'd welcome Dr. Ben. Thank you.
Hey, everybody. Good afternoon. Can you guys hear me okay with this level? Yeah. Excellent. All right. My name is Ben Wildman Tobriner, but yes, Dr. Ben is totally fine. Even just Ben, totally fine. Thanks, everybody, for being here, and thanks for the invitation for coming to chat.
There's the laser pointer, too.
Thank you. Awesome. And like we said, I'm one of the radiologists, and we're going to talk a little bit about alphabet soup. So CT, MRI, ultrasound, and all sorts of fun acronyms for the next few minutes. I'll try to keep us on track in terms of time. Today, we're going to talk for a few minutes about who am I and radiologists and what we do. We'll talk about why imaging in terms of diagnosis, screening, and transplants. We'll get into some details about ultrasound, CT, and MRI. We'll touch a little bit on elastography and a few comments on biopsy. For each of those later ones, we're going to talk about a little bit about how does it work, what's it like, what do images look like, and what will my reports say. Before we get too far into this, though, I'd like to know a little bit more about you all so I can kind of know my audience a little bit. So just by show of hands, who here is from out of state? Oh my gosh, that's incredible. Welcome to North Carolina, my humble state. For those of you who haven't been here, you're catching it at a beautiful time of year. There's some red leaves around. Anybody from California? All the way from the, hey, so that's where I was born and raised in Northern California, and so we don't really get that, right?
Right, we don't.
Yeah, it's to kind of, we get fog. I'm from San Francisco, so we get fog and all that. But yeah, it's a beautiful, beautiful time of year, so happy you're here at a great time. Excellent. So getting a little bit in towards my neck of the woods, who here has ever had an ultrasound? Show of hands. Lots of folks. All right. So this won't be new stuff, but we'll see if we can clarify a few things. How about a CT scan, also known as the CAT scan, if you will, and maybe an MRI. MRI, few less, still a lot of hands. All right, so as we can see just by looking around the room, radiology influences and touches on everybody throughout. Maybe it's related to your PBC, but maybe it's not, right? Maybe it was your knee or your neck or something, who knows what. But radiology is ubiquitous throughout medicine, and some of the stuff that we talk about here today will be applicable not only to PBC, but to your life in medicine in general. And if you can learn something for that, that's excellent as well. Okay, so a little bit about radiologists, who we are. So we spend a lot of time in dark rooms, as evidenced by that picture. So we are MDs or DOs, that's medical doctors or doctors of osteopathy, but either way, we're doing 4 years of postgraduate training. And then after that, once you have your MD, you do a residency in radiology. So that's a 5-year residency. And then many of us go on to do a little extra subspecialty training. For me, it's abdominal imaging, which specializes kind of in this vicinity from here to here, including the liver, one of the most important organs, obviously. And so most importantly, though, we are members of the team. So we work a little bit behind the scenes, right? You don't always meet your radiologist. For those of you who have ever had a mammogram, you may meet your radiologist. That's one point of contact where radiologists have a lot more interaction with patients. But most of the time, we're called the doctor's doctor. We kind of talk to your doctors a lot more than we necessarily talk to you. So it's great to be out in front of you guys and meeting you all. I guess one little point of clarification is that there is a distinction between a radiologist and a radiology technologist, or a rad tech, if you will. So those are folks who go to extra postgraduate years of school as well. Those are the folks who are taking your x-rays, or taking your CT scan, or taking your MRI, or even doing your ultrasound. We like to refer to the ultrasound techs as sonographers. That's a more appropriate term for them, but those are equally important team members, but not the same as a radiologist. So this is you in the center of your care, and probably most importantly on either side of you in terms of your medical care are your hepatologist if you're a PBC patient, and then your primary care doctor, your PCP. But there's other doctors kind of floating in the periphery, such as radiologists. So I may have seen you even if you haven't seen me. And if you've ever had a biopsy, then certainly the pathologist has seen little itty bitty pieces of you, your cells, but not you. And then if you ever are going down the transplant pathway, you've definitely seen a surgeon, maybe probably more than once. So lots of folks floating around this care. This is sort of modern medicine, right? Complex care, lots of people contributing. So who am I? This is me in a very posed picture, standing next to a CT scanner. I think this is still on the Duke Radiology website somewhere. That's actually one of my colleagues as a patient, but there's a CT scanner there. So I'm from Duke, so I live 10 minutes from here, and I've been here for over a decade now in North Carolina. As I said, I'm an abdominal imager. I spend most of my time doing image interpretation, so I look at CT scans, x-rays, ultrasounds, and MRIs, and then I also do a little bit of procedures. So 1 or 2 days a month, I'll do procedures, which include liver biopsies, which we'll get to in a little bit. So why imaging? As we said, it's pretty ubiquitous throughout medicine, pretty important. And some of the stuff we're going to touch on comes from this. You guys may be familiar with some of the AASLD practice guidelines. So we refer to this not only for PBC stuff, but for all sorts of liver-related disease, if you will. So why imaging? Well, we use imaging in the setting of diagnosis of PBC. We use it in the setting of screening for select patients, and we certainly use it in the setting of transplant. So let's talk about each of those for a minute. So for diagnosis, as you all know, the diagnostic criteria for PBC really does actually not center around imaging, right? You need to have, by definition, evidence of cholestasis with a chronic elevation of your ALP enzyme. You need to have tested positive for AMA antibodies or other PBC-specific autoantibodies. And/or have some histology. So 2 out of 3 of these can qualify you for a diagnosis. So that doesn't mean that there's no imaging, even if it's not central to this. So especially for the first one, for cholestasis. If you have cholestasis, meaning you have chronically elevated liver labs, if you will, particularly ALP, you're probably going to get some imaging. Specifically, one of these 3 that I just talked about, one of these big ones. And the reason is because we're looking for other reversible causes of biliary obstruction, that's obstruction of your bile ducts, or liver pathology that might be something else that is sort of fixable, if you will. There's a big differential when you have cholestasis, and that includes other alphabet soup things like PSC, you guys are probably familiar with that, primary sclerosing cholangitis, autoimmune hepatitis, AIH, drug reactions, and then biliary obstruction itself, a mechanical or extrinsic compression of the bile duct, lots of other causes. So you're probably going to get some imaging. Once some of those things are ruled out, then you get some blood tests, and you may end up with a diagnosis of PBC. Now, for AMA, we know that's a blood test, so not so much imaging there. And then for histology, also known as biopsy, we, as I said, radiologists may be involved in your biopsy. We're certainly not reading the cells. You can see floating in the background some cells there, but not super radiology central. But for that diagnostic part, definitely radiology plays a role. And then let's talk about screening for a second. Screening is super important in certain populations. And when we talk about screening, we're really talking about screening for HCC, or hepatocellular carcinoma, which folks with cirrhosis and end-stage liver disease are at risk for. And so not everybody gets screening who has liver disease, but specifically it's based on risk. So in this population, men get screening, and then folks with cirrhosis get screening. And typically you get screened every 6 months with ultrasound, plus or minus an AFP, which is another alphabet soup, alpha-fetoprotein, that's another lab value. Depending on your ultrasound and how it is, you may also get screened with a CT or an MRI. So again, radiology plays a central role in screening. And then if you end up going down the transplant pathway, we use more radiology. So we continue to do HCC screening even if you're on a transplant pathway. And then CT and MRI are super important for looking at anatomy in the pre-transplant stages, figuring out if there's anything. Surgeons don't like surprises, so we want to make sure we know everything going in ahead of time. And then post-transplant, we still do HCC screening. And then transplant monitoring, super important, imaging, very, very helpful in that setting. All right, so we're going to get into some of these more alphabet soups, but the US, the CT, and the MRI, or as I would say, ultrasound, CT, and MRI. So let's talk about ultrasound for a second. So how does it work? Ultrasound is based on sound waves. So we can see here there's a little cartoon, if you will, of a transducer, and it emits sound waves which go into your body, emitted by that probe. We call it a probe or a transducer. They bounce off objects inside your body and then reflect back to the probe. And depending on how fast they reflect back and the intensity of that reflection, then we can reconstruct pictures. I say we like I invented it, but no. We can reconstruct pictures that you're probably familiar with. So basically just putting sound waves in, sound waves come back out. Fancy math, ultrasound. So here is a typical ultrasound machine that you might see. Depending on the exam you're getting, there's different types of probes. So that one on the left has a little curved surface. That's called a curvilinear probe. That's typically what we use for livers. So what is an ultrasound like? Well, all of you, pretty much everybody raised their hand, so y'all know. But it takes about 30 minutes for a liver ultrasound. They're performed, as I said, by sonographers, not us. So when you ask them, what's going on, they don't tell you, not because it's some HIPAA medical thing. It's that they have to show it to us, and we talk to them and work with them to get to the conclusion. So that's why they don't want to say the wrong thing. They definitely know what they're looking at, but it's a team effort, and they want to wait for the finished product before telling you anything. There's gel, as you all know. A little bit of pressure, kind of have to push a little bit to get in there, but nothing painful, as you guys have seen. And then ultrasound is quote-unquote real-time examination, meaning the sonographers are looking around in real time, almost like with a flashlight, right? Kind of turning it on and looking around, taking pictures when they see something, or in a standard sort of sequence, or when they see something worth taking a picture of. But it's definitely a real time. They work with us to tell us what they're seeing. And then it's ultimately interpreted by a radiologist. So what do the images look like? Well, here's sort of a pretty standard looking ultrasound image of the liver. They often have labels at the bottom, which is really nice, so you can even for me, so you can sort of see what you're looking at. So typical ultrasound images are grayscale, meaning they're black and white. And then a typical liver ultrasound includes the liver, things that are nearby, like the gallbladder, the common bile duct, which is the big one, but also the intrahepatic bile ducts, ones inside the liver, the right kidney, and maybe a little bit of pancreas, though it's harder to see. Then we can use a little bit of physics and what's called color Doppler to image the blood vessels. And so when you see color on your ultrasound images, then they're looking at what direction the blood is flowing into and out of the liver. So we look at the major arteries and veins when we do a liver Doppler. So here is, and then we talked about that being a real-time examination and sort of the flashlight effect. So this is what they're doing. They're really kind of looking, let's see if this will go for me. There we go. They're kind of looking back and forth through, this is like what a real-time ultrasound of the liver is going to look like. And I'm going back and forth, so this is actually this little dark stuff over here is the gallbladder, and then this is the liver, this big gray blob. And I remember when I first started radiology training, it really does look kind of like a snowstorm, but eventually you kind of figure it out after you look at a couple thousand of these bad boys. But the dark stuff in there, in the liver, are blood vessels. And then this is the curved surface of the probe, so we know that's that curvilinear probe, and that's sort of the cone of sound beams going out down into the body. That's how it has that shape, because that's the direction the sound beams are put out. So that's kind of what a typical liver ultrasound looks like. So what will my report say when I get a liver ultrasound? We're going to take a little break from ultrasound and segue into some basics on radiology reporting, which I think is applicable to all of medicine. So radiology reports are usually broken into a quote-unquote findings section and an impression section. So the findings section, outlined here in gray, is where the radiologists put all the stuff that we see, kind of like a laundry list of stuff. So you can see here it's broken into sections. So there's a section about the liver right there, and then a section about biliary, which is bile ducts, and then the pancreas, and ascites, which means it's their fluid in your belly, and the renal stuff, and so on and so forth. And then at the bottom is kind of the money. That's the impression. That's where we coalesce all the findings into the meaningful and actionable stuff. So except if you're not a radiologist, most folks just go to the cliff notes at the bottom, right? Just go to the impression. That's really like the good stuff. And then if you want to clarify anything, then you can go back up. But I say this because in the past 5 to 10 years, the concept of the patient portal has exploded. So patients have total access to everything. And for better or for worse, y'all can read the radiology reports, right? And should always be done in concert with your ordering doctor. But if you're at home reading this, at least I want to give you some basics about how this is kind of what we're thinking as we structure this. So then there's a question of sort of structured versus free text. The example up here is an example of what I would call a structured report, which is it has those sections, and that's also becoming increasingly popular. 10, 20 years ago, it would just be a paragraph of text, because 20 years ago, we used to dictate into a microphone, and there'd be a transcription service, and so on and so forth. But now it's all done in front of us on a computer. We're our own text editors, and it makes it really nice to have it be it's basically much more organized in this fashion. But you will still see some free text reports out there where it's just a paragraph. And that's it, one run-on sentence. But there will still be an impression at the end, as is in the case here. We also like to use guidelines. Radiologists love our structure and, like I said, guidelines, and we'll talk about that in a second. And so at the bottom here, you'll see this term, and some of you may be familiar with this, LIRADS. So what does that mean? That's part of a guideline. So speaking of which, LIRADS is very important in the liver world, particularly in the HCC screening population, which some of you may qualify for. So LIRADS stands for Liver Reporting and Data System, and it is a classification system for HCC, for hepatocellular carcinoma. And it can be applied to ultrasound, MRI, and CT. And so when we're looking at an exam, any of those modalities, and there's a question of HCC or HCC screening, we are using and applying LIRADS. So you will see that in your radiology reports. And there are different rating systems for ultrasound versus MRI and CT, two different buckets. And the LIRADS is integrated with the AASLD guidelines, so they're all in cahoots together. Okay, so back to ultrasound. That was a little bit about reports. So for ultrasound specifically, what will my report say? Well, it's probably going to be a structured report. That's the same one you just saw. We're going to comment on each organ. And then if this is a liver screening exam, we're going to use LIRADS. So LIRADS in the ultrasound world gives you a grade of 1 to 3, and that's based on, do we see anything suspicious in the liver? Do we maybe see something suspicious, or do we definitely see something suspicious? It's basically that simple. It's a no, a yes, and then there's kind of a maybe in the middle. So that's 1 to 3, and then we also give it a quality rating, A to C. A, we can see perfectly. B, we can see pretty good. C, it's really hard to see, because that's going to influence how much we can see, how sensitive we are for detecting suspicious lesions. So then we put that together. You get a letter and a number. So at the bottom here, you get LIRADS, ultrasound, US, 1B, negative, meaning we didn't see anything. Looks okay. And then, of course, we're going to rule out other liver abnormalities, like we said in the setting of diagnosis, where we're not sure what's going on yet. We're going to talk about the bile duct and the veins and all sorts of other stuff that might be causing liver problems. And then we use it in the screening setting, too. Okay, we're going to talk for the next few minutes about CT. So I know that back when, maybe, I don't know, 20, 30 years ago, we used to call it a CAT scan, but that makes, you're not a cool kid if you say CAT scan, so just call it a CT. It makes it sound much cooler, okay? So how does it work? CTs use X-ray beams, just like regular X-rays, just a little bit fancier, and a few more of them. But basically, as you can see in this diagram over here, you take an X-ray source, and you spin it around the patient. It's really as simple as that. And while it's spinning, as you have experienced, you move through the thing that's spinning. So it ends up doing like a spiral, like a DNA shape as you go. There's detectors that receive those X-ray beams, same idea as a regular X-ray, just more of them and fancy math to reconstruct things more in 3D. There is the donut, as you've all seen, but it's kind of a short donut, so not real claustrophobic, and you only are in it for a couple seconds. So when we do CT scans, we might do between 1 and 3 acquisitions, as we call them, also known as scans. So you might go through it 1, wait a few seconds, 2, and up to 3 times, depending on the exam that you're getting. And then we do multiple reconstructions, which we call reformats. And that's reformatting that data into different ways. So like either you're looking at me or you're cutting through me, or we're going to talk about that in a second. So what's it like? Here's a CT scanner. I'm not standing next to this one. But you probably will get an IV because we're going to give IV contrast. So that's the dye, if you will, that goes through and really kind of turns on the lights for us and lets us differentiate between different parts of the body. The acquisitions that I just mentioned, they're pretty fast. So they're between like 3 and 10 seconds. So you zip through that thing pretty quickly, especially with modern CT scanners. Again, 10, 20 years ago, acquisition might have been 30, 50, 60 seconds, but now they're super fast. And when we do those are based on the contrast going through the body. So you can imagine if we put it in your arm right here, it starts going into your heart, starts pumping out everywhere. So we have a timing system, and we take different pictures depending on what we want to see and when. So that's why we might do a couple of different acquisitions, because we want a picture early on, and then we might want another picture later on. Contrast, for those of you who had it, can make you feel a little warm inside, but it's really not too bad other than that. All right, so CT, what do images look like? So I had a mentor who used to say, ultrasound, an X-ray is kind of like looking at somebody's shadow. An ultrasound is like looking around the room with the flashlight, and a CT is like turning the dang lights on, right? So it's much, much easier to look at. There's so much more information with a CT scan. And so I alluded to this just a second ago, but we'll talk about some basic orientations because you're going to see some words about this in your reports when you read them. But this is a basic axial plane. So this is like a loaf of bread style cut, right through anywhere sort of transverse to your body, like a slice of bread. And so what does that look like in a CT scan? It looks like this. And so there's classic radiology orientation for all studies, chest X-ray basics all the way up to complex MRIs. It's always backwards, right? It's always the right is left and left is right, because it's always like we are looking at the patient. And so not only that, but there's always a convention of the patient. In this case, if you can imagine somebody laying down with the feet pointing out of the board, head pointing into the board. So if you're laying down like this, my right side is over here, my left side is over there, which is what this is. And so this is a typical axial slice. Radiologists, we live in the axial world, which is very counterintuitive unless you live in that world and review all of your images like that. A much more intuitive world is the coronal world, right? This is cutting down as if all the textbooks in anatomy you've seen when you're a kid in a biology class and all that, it looks like this. So this is like you're looking straight at somebody head on. And these are images that probably look a little bit more familiar to you, but the radiology convention remains, which is that this is the patient's right side and that's the person's left side, because this is like somebody standing at you, looking at you now, right? So that's their left, and that's their right. We spend some time in the coronal plane. It gives us a nice second look. There's an old adage in radiology that one view is no views, right? So it helps to see things from two perspectives. And then there's still a third plane, though, and that's the sagittal plane. So that's like standing sideways and having somebody cut you that way. And we use this a little bit less, but because it looks like this. So the thing we use it most for are the bones, particularly the spine, because it lays the spine out in one plane perfectly. So you can see the entire vertebral column and those little spinous processes pointing outwards, so not the liver, but we use it for bones pretty much. We don't review things like the liver and all the biliary stuff. We don't use sagittal for that, but a word that you will see. And so then it's not left and right because they're standing sideways. This becomes front and back. A little quick anatomy and physiology refresher in the liver. The liver is super complicated, a lot going on. It does a lot of very important things in the body. And so if you look at some basic anatomy drawings, they can look pretty complex, but we're gonna break it down and make it pretty simple. So there's some things going into the liver. First and foremost, there's arterial blood going in. It goes via the hepatic artery, AKA kind of the liver artery. That's the red stuff in that diagram. There's also portal venous blood going into the liver. So even though it's venous blood, it still helps supply the liver with oxygen that it needs. In fact, 75% of the blood supply to the liver comes from the portal vein. So the portal vein is what's draining everything beneath the liver. So all the bowel, all your intestines, all drain eventually through the portal vein into the liver, because the liver's a big filter, right? So it's taking all the blood that's come out of the bowel and filters it. It does a really important job. And then how does blood get out of the liver? It goes out the hepatic veins and makes its way towards the heart. Now we know that's not all the liver does. It's not just filter, it also makes stuff for digestion, right? So it's also creating bile going out of the liver down. We know that's stored in the gallbladder, and then it makes its way down into the bowel where it helps with digestion. So that's some basics that you'll see some comments about all of those structures in your reports. So CT, what do images look like? Well, to me, they look great. I love CTs. It's amazing technology. We're gonna comment on each organ. If this is a liver screening CT, we're going to use LIRADs. And unlike the ultrasound, where it was a scale of 1 to 3, this is really a scale of 1 to 5, or in reality 2 to 5, where each step is a slightly higher risk of HCC. And then it's super useful in the diagnostic setting for ruling out other liver stuff. So since you guys are now all budding radiologists, we're going to have a look at this one, okay? So this is an axial image, so the patient's right is on this side, patient's left over here, this is starting up in the chest. And then we're scrolling inferiorly towards the feet. These are big old black things on either side of the lungs. We got the heart, that's an important one. And then this big old thing is this vertebral body, the spinal column, if you will. As we come down, we get to the best organ, and that's the liver. And it lives up here, as you all know, in your right upper quadrant. That's what we would call it. And it's pretty big. It's one of the biggest organs in the body, right? It even crosses over and gets over to the left a little bit. And so this is what I'm looking at. This is what I spend a lot of my time doing, is going back and forth through the liver on a daily basis. Might sound boring, but I love it. And so we're looking at all kinds of stuff. But importantly, we talked about the portal vein, this big old bright thing. That's the main portal vein. That's a big important one. And so it gives off, as you can see, kind of just like your airways and lots of blood vessels, it has sort of a branching pattern, right? That arboreal pattern, as you can even, pardon me, we can follow it and see kind of how it goes up into the liver. And then these guys up here, they're all coming together. These ones tapering up here, 1, 2, and 3. Those are the hepatic veins. And then this is the inferior vena cava, which is the place where these hepatic veins drain into, and that goes right into the heart. So that's blood going out of the liver. So lots of other structures in here that we're not going to go into, but we can see all the solid visceral organs, the spleen, the pancreas, gallbladder, kidneys, adrenal glands, all that good stuff. But this is a pretty normal looking liver. But yeah, that's what I do. And then I'm dictating as I go, commenting on things. So here's just another comparison case. This is somebody with an abnormal liver that I want to show you just to compare. And so unlike that last liver, which had a very smooth surface, if we look at the surface of this liver, it looks very lumpy, bumpy, right? So this is what starts looking like when you have cirrhosis. There's a few different signs that we see, but as I pan back and forth, everybody can see that thing is pretty lumpy and bumpy, right? So that's a sign of cirrhosis. And then down here on the inferior edge, you can still see all these little lobulations, right, all the way along the surface. It should be smooth, but it's bumpy. So this is somebody with chronic liver disease, not sure the underlying cause, but that's just a sort of a general look. All right, we're going to press onwards. What will my report say? Well, we're certainly going to comment on the liver overall. We're going to comment on if we see any liver lesions, aka liver spots, liver masses, liver tumors. They're all sort of uniform terms. We're going to look at the blood vessels, like we just pointed out the portal vein. We'll talk about the biliary tree, aka the bile ducts, right? Same thing, they have a nice branching pattern as they go out into the liver. And then there's lots of other organs and structures that we're going to look at. This is just an example of a CT report. I didn't put the impression down at the bottom, but again, just to show it's structured, there's a section on the liver, and then if we see focal hepatic lesions, there's a mention of a LIRADS3 lesion, so that's low intermediate risk for something being HCC, and then we go down and talk about more stuff. All right, the last sort of major modality is MRI. How does it work? I don't actually know. Whoever invented MRI is amazing. No, I know a little bit. So it's based on, the technology for MRI is totally out of this world. It really is amazing, whoever thought to do this. It's based on magnets and a combination of magnets and radio waves. And so because it requires a really homogeneous and uniform magnetic field, we have to have a really big magnet. And it has to be that has to be pretty tight. And that's what gives us the long and small donut that you're all familiar with, which is definitely a little more claustrophobic. Because to get good images, that magnetic field has to be perfect, essentially. And so you don't know it, but when you go into a room, there's actually a cage of I guess it's copper wiring around your MRI room. It's almost like a Faraday cage to try to eliminate any electronic interference because that signal, it has to be so perfect. But when it is, we get these amazing images. So we do many acquisitions. Unlike the 1 to 3 from CT, we do double digits for sure, sometimes 10, 15, or even 20 acquisitions when we're doing MRIs. There's more time points than CT as a result, so we can see things at lots of different points. But one of the problems with MRI is very motion sensitive because everything takes a little longer. So in terms of breathing or scooching around, because we're getting a little antsy inside the scanner, it happens to everybody. So it's very motion sensitive. So what is it like? There's an MRI scanner. Excuse me, just like with CT, same thing. We're going to get an IV to get IV contrast because it's super important to help turn on the lights. We may have also a unique thing for MRI, which is an organ-specific coil, which means we have some receiving coils that receive those radio waves, and we want to get them as close to the organ of interest as possible. If you've ever had a brain MRI, you get that little cage right around your head, which seems a little weird, but that's because we want the coils to be close to the head. And if you get a liver MRI, they may put a little mini coil right over your belly, and it's just to receive things closer. It's like listening from close or listening from far away. You'd rather listen from close. The acquisitions are slower, so we said 3 to 10 seconds for a CT. Acquisitions may be up to several minutes for an MRI, depending on what we're doing. MRI, for those of you who have had one, is super loud. They'll give you earmuffs or earplugs because it's really, really loud. And then it's a mix of BH, which is breath hold. So they may say, hold your breath, and you got to hold your breath for anywhere from 5 to even like 20 seconds, can be a little hard. Or free breathing. We have technology that lets you keep breathing, but it's timing the acquisition with your breathing. So we are tracking your breathing, taking pictures right at the right moment every time so it adds up instead of it having that motion artifact of your breathing. So all in all, with an MRI, certainly takes longer than a CT scan, more like 25 to 30 minutes depending on what we're looking for. What do images look like? They look a lot like CT. We have the same planes that we talked about, but so we can see anatomy similar, but there's more information because of the multiple time point phenomenon. So here's an example where we took a picture just after the contrast went in. There's some bright contrast in the aorta right there. And then we took a picture like 7 seconds later, and a little bit has changed. Here's the spleen getting brighter. There's some blood, there's some opacified blood or some bright blood in the liver now. And then again, we take like 1 minute later, we get another look. And believe it or not, each of those, even if they're a few seconds apart, we get really important information on how things are behaving from taking multiple time points. So that's the power of MR. What will your report say? It's similar to CT. You're going to see some LIRADS terminology. You're going to see complications of chronic liver disease, just like we would with CT, and lots of other organs and structures. All right, we're going to finish up with elastography, which is not my area of expertise because I don't perform it, but I am certainly aware of it. And we work with our gastroenterology colleagues to make sure everything is all good with elastography. But elastography is based on a vibration and an ultrasound. So basically putting out a little vibration and ultrasound, same principle, sort of listening to it as it comes back. And what it's doing is it's measuring the stiffness of the liver, AKA the hardness of the liver. And so it's been proven to correlate really well with the degree of fibrosis and cirrhosis in the liver. So a pretty neat technology. We do this in clinic, not in radiology. There's no images associated with an elastography. So it is not the same as an HCC screening test. It's simply to look at liver stiffness. And so what's it like? It's non-invasive. You might feel a small vibration as it's kind of clicking away, but it's super fast. It doesn't take very long. There's no images, as we said. What will your report say? It's going to be a pretty short report. It's going to give you your stiffness in kilopascals, which is the unit they report in. And there's different cutoffs for different types of liver disease. So this is taken from the Memorial Sloan Kettering website for folks with cholestatic liver disease. And there's different cutoffs. So if you get an elastography and it has your KPAs between 2 and 7, then your fibrosis score is probably an F0 to F1, and your liver is normal, and then all the way up through cirrhosis. But these numbers and cutoffs change, as I said, depending on what kind of underlying liver disease you might have. But to really know the F score, which is how much fibrosis you might have in your liver, before I go on to that, we're going to look at potential pitfalls of elastography. If you've got fluid in your belly, ascites, that can mess it up. If you have a congested liver in the setting of heart failure, that can mess it up. If your liver is acutely inflamed with hepatitis or drug toxicity from a medicine, it can also skew the measurement. So just a few pitfalls. And then if you have biliary obstruction, which you would probably know from labs, acute biliary obstruction, you would know it can also have some negative effects on elastography. But as I was saying, to really look at the F score, we've got to do a liver biopsy, which is still the gold standard for diagnosis. It is, by definition, the percutaneous, which means through the skin, sampling of random liver tissue. So this you might recognize since we looked at it a little bit ago as an ultrasound of the liver. Here's our curvilinear probe, and then this big old blob's the liver, and then this bright line is the needle going just inside. There's no need to go like right in the middle. We just take a little sample from the outside. We typically do what's called a core needle biopsy, so actually do take a very small but real chunk of liver tissue, performed by often radiologists, sometimes gastroenterologists, more so these days by radiologists, and as I said, remains sort of the gold standard for diagnosis. What's it like? We make a teeny tiny hole in your skin, lots of numbing medicine. You may or may not, depending on where you get your biopsy, get a little bit of mild sedation, but you'd probably still be awake. We take good care of you. They're not so bad in general. We usually use image guidance to do it. We don't just randomly stab you in your belly, right? We're using an ultrasound machine. At Duke, we use ultrasound because it's really fast and easy, and we get that real-time look. We're kind of shining the flashlight and seeing where our needle's going. You can also do it with CT, fine either way. The whole thing probably takes 30 to 40 minutes, but the actual procedure, the actual pokey part is really short. I can do it in less than 5 minutes. So looking ahead as we wrap up here, what's coming in radiology? So now, I mentioned at the beginning, access to reports, that's relatively new. Even newer is access to images. Apply with caution, right? We're all familiar now with radiology, but please don't look at them all by yourself. The future, though, is patient-centered reports, which is cool technology that's coming out. I have a friend who has a startup company in this arena, which is taking those alphabet soup-filled radiology reports and automatically translating them into a patient-friendly, navigable report. So you'll see probably some of that, if you haven't already, in the future. Some of that's in practice at various places. And then we're also always developing more technology. Hard to know what the future holds, but there's certainly going to be some disease-specific contrast agents. I know for sure there's some contrast agents for the liver coming out where they'll be able to kind of quantify fibrosis based on imaging, and contrast agents that really sort of illuminate areas of fibrosis. So that is really it for me. We know that radiology and PBC gives us a detailed evaluation of the liver, helps in the diagnosis arena or in screening. As radiologists, we often work behind the scenes, but we are happy to be a part of your care team for sure. Thanks very much.
Thanks, Dr. Ben. I have a few questions and comments. First off, great presentation. How often do you get out of the dark room and interact with patients or on the comedy circuit?
On the comedy, Thankfully not on the comedy circuit. So I do procedures probably 2 to 3 days a month.
Okay.
And so those are nice days I get to meet everybody and I meet somebody for the first time and have to convince them to let me poke them with a needle within 5 or 10 minutes. So
Yeah.
A little levity goes a long way often.
Yeah, I would imagine. I'm glad that didn't seem like too many people had PTSD from the images of the needle biopsies, so that's good to hear. And I had a question too on EUS.
Yeah.
There's a question, does it stand for endoscopic ultrasound, or is it the elastography, and is it for looking at the pancreas?
Yes and yes. So EUS is another alphabet soup. Absolutely. That does stand for endoscopic ultrasound. So endoscopic things, if you will, are done by gastroenterologists. So that's where they're putting an ultrasound probe down your esophagus into your stomach and using that window to look around at whatever it might be. Often you can look at the pancreas because the pancreas is just behind the stomach. Not so good for the liver because the liver is actually closer to the skin often than it is to the stomach. So we use EUS, the gastroenterology colleagues use EUS for the pancreas often. Maybe some of the bile duct nearby, but I would say most commonly the pancreas.
Okay. And another question on the spleen and being part of kind of the US testing protocol. How often is it typically in the protocol for doing the?
Yeah, it depends on exactly what you said. So the word protocol to us means how are we going to do this imaging exam? And so different institutions have different protocols. So our routine liver protocol does not include the spleen, for example, but other places may. It's on the opposite side of the body, kind of far away, and so we typically don't. For our liver Doppler protocol, which is kind of like a liver plus, if you will, and we're looking at the blood vessels, then we do scooch over to the spleen and look at that. And for folks who have cirrhosis and portal hypertension, where they get a big spleen, splenomegaly, sometimes we'll look at it. But our quick and dirty, if you will, our routine liver does not include the spleen.
Great. Awesome. Thank you for your time.
Yeah, thank you guys.